I was given the task today of talking a little bit about some of the challenges we're experiencing coming out of COVID. More importantly, what are we doing about them? And how does that sort of impact the future of healthcare and where we need to go? So if you don't mind, I'm going to try to screen share. Since I struggled to get off mute, we'll see how well this goes. So overcoming challenges to progress in a post-COVID world. I know you all live and breathe this every day, not just in your work lives, but in our home lives as well. It's just continued to be a struggle, but I'm optimistic that we're getting there. We're emerging and hopefully in a better place than we were 2.5 years ago. I'll just start with a little bit about my place of employment, the Johns Hopkins Hospital here in Baltimore. We were founded in 1889 by a Baltimore businessman, Mr. Johns Hopkins. Yes, his first name was Johns with an S. He was named after his great-grandmother, Margaret Johns. And he had no children, he never married, but he left his money to form the first university and hospital that would be partnered together. I sort of like to think of it as perhaps the first academic medical center, because a university and a school of medicine partnering with the hospital were unheard of in the day. But he was very clear in his directive to the first board of trustees that we would continue to be excellent in our innovation mission, try to discover the cures of tomorrow. I think this is where you guys, many of you have embodied research in your own careers. So we hold that pathway very dear. But he also said you will be the community hospital for East Baltimore. So we pride ourselves in trying to take care of our local community here. We have a few designations that I always put up just because I'm so proud of my colleagues. Every day we work here together, everyone from those serving food out of our kitchens, cleaning our rooms, to our nurses, our physicians, our physical therapists, occupational therapists, everyone rowing in the same direction. So I put a few of our designations that we're proud of. I'm not going to read them all to you. And then Jana already told you a little bit about our hospital. We're reasonably large as far as hospitals go, 1,100 beds. We admit about 54,000 patients a year. You can see some other statistics, almost $3 billion in operating revenue and 11,000 employees. Our medical staff is pretty large, 2,300, and our allied health staff recently at about 880. So that's a little bit of background about, the place where I work. And despite calling out a little bit about what I think makes us unique, I will tell you the challenges we're facing. Everyone is feeling it everywhere. I know you guys are in your respective institutions. So I want to talk a little bit first about what are these challenges, and then I'll segue into what we're doing about them and where I think we need to go. I would be remiss if I didn't mention staffing. We have just lived through the Great Resignation. It was understandable that so many people were juggling COVID, issues at home, sick relatives, children not in school. And when they came to work here in the hospital, everyone was stretched thin, trying to make sure we saved lives. The burnout was palpable. And here we are 2.5 years later, and we have not made as much progress as I would like as far as replenishing our numbers. Silos in healthcare. You all know what this is like. You have family members who feel lost. Who do I need to see? What's the next path forward? The fragmentation is palpable. And so how do we tackle that? And then finally, I put patient consumerism. Some people bristle at that notion of consumerism. And, is that really an appropriate word? But I do think because patients are paying more and more out of pocket. They are. High deductible plans, increased premium costs. Patients are demanding excellence in medicine. They're demanding high value. They want access. They want convenience. And they want technology. And I'm going to say a little bit more about these three on the next few slides. So let's start with staffing. I think these challenges are staggering. Since 2016, the average hospital in the US has turned over about 90 of its workforce, 83% of its nurse staff. And the turnover rate just continues to increase. In 2020 here at my hospital, we were around 19%, 21%. It's now in 2021, it's now at 27%. And forgive me, those are national statistics. But I will tell you, each of our hospitals are looking at similar numbers. In a recent survey, I find this fascinating. 62% of nurses said they're thinking about leaving the field still. And if you ask hospital leaders what they feel, 64% of them said we're trying to hire. They see the silver tsunami coming. Baby boomers aging, they're going to require more care, more intensive inpatient care. And so this is a collision course right here. You know, I will tell you personally at the Johns Hopkins Hospital, those 11,000 employees I mentioned, right now our vacancy rate is around 1,300. So we are trying to care for the same number of patients with 10% fewer staff members, and it is hard. So it really requires us to think about new models of care. And this is where you guys come in. How can we do things more efficiently and better without sacrificing any safety or quality? The second challenge I mentioned on that first slide, and I love the silos. I grew up in Southern Ohio, so my grandparents were all farmers, so I resonate with this slide. But post-COVID challenges, and it's the silos, the fragmentation in healthcare. We all know it, right? We have a relative who's diagnosed with cancer. Do they see the medical oncologist, the surgeon, or the radiation oncologist? Who's navigating and quarterbacking that care? How do they know that they're getting exactly the right pathway they need? I could repeat that story on and on. Or we see our internist in the office and our specialist at an AMC or at a different practice, and the communication isn't where we need it to be. Or we have a relative who is in the hospital and then ends up going to a skilled nursing facility or a rehab facility, and the communication just isn't there. It is really incumbent for us to break down these silos. Why? Because it leads to gaps in care. If you don't have that transparency and communication, you miss things. And I always worry about the patient being harmed if you don't have that complete communication. And then how do you make sure that you're progressing the care plan forward? So I can't emphasize enough how important this is. And then finally, this notion of consumerism. You know, as I mentioned, patients are paying more. So they are demanding that we rise to the occasion. They are. They want convenience. I know many of you, you're probably like me. I think about how I used to grab coffee 6 years ago on my way in. Now I order it up on my app, whether it's Dunkin' or Starbucks. And if I arrive in that store and it's not waiting for me steaming hot at the counter, I'm cranky. Like this, what has happened? We want our groceries demanded. We want to drive up to Target and have things loaded in our car. We are a convenience-focused society in all aspects. And then high tech. This picture, my kids, they do things on their phones. I have a 13-year-old and a 17-year-old. They do things on their phones that I never dreamed I would. You know, we Uber, we look up things, we connect. So those are the themes I would say. Our patients want access, they want convenience, and they want high tech. And I'll tell you what, we as health systems, if we don't deliver that, we face irrelevance. So I put on here a couple of examples. You know, 10 years ago, who would have thought that CVS Health would be the fourth largest company in the world, number 4 on the Fortune 500. They started out as, you know, CVS. They went into the provider realm. They started minute clinics where you can go see a nurse practitioner in the minute clinic for your cold, for a vaccine, everything you need. So they have a provider network. They bought Caremark. Caremark, as you know, is a pharmacy benefit services, and they can take care of your prescriptions and deliver them to your door. And now they're getting into bigger provider space. So we know that they just are making a play for Signify, which is a home health they're a home health provider, and it's not clear what the strategy is, but they're thinking, gosh, we need to be a part of that continuum of care, a vertical integration. How can we serve patients in so many different ways? And I will say CVS Caremark also bought Aetna, which engenders them 3 million plus covered lives, Aetna, the insurance provider. So this is the kind of vertical integration that we are facing and have to be able to compete. Let's take a look at Amazon. How many of you use Amazon? I think I'm addicted. I honestly do. I know I may pay a couple dollars more, but the fact that I can have the selection and get it delivered to my door within 48 hours and I never have to leave is just too tempting. Amazon is moving into healthcare. They have a distribution system that is unparalleled, backed by Amazon Web Services and the infrastructure that makes them a formidable competitor. They bought PillPack. So now, they can deliver medicines to our patients that are already Monday, Tuesday, Wednesday, Thursday, Friday. It's already spread out for you so you can take everything you need. And now they're going to be buying One Medical for $4 billion. One Medical is a primary care group, 200 locations across the country. They offer virtual services, 750,000 member patients. They're getting into the healthcare delivery space. So I think these are interesting times. And those of us who work in more traditional environments, practices, healthcare systems, we need to pay attention. So this brings me to my next thought. I have this picture of a highway. And I liken it to, I told you I'm from Southern Ohio. I came to Baltimore 34 years ago as a med student. I've been here ever since, 34 years. And I think back to my first years in medical school, how I would drive to my home in Wheelersburg, Ohio, right on the Ohio River near Kentucky and West Virginia. And it was an incredibly circuitous route. There was no Interstate I-68. It would take me easily to get to Wheelersburg, 9 to 10 hours. And it just was, it was cumbersome. If you had one traffic accident on that lane, you can add hours to your trip home. Bodily functions would often have to wait. I mean, this was horrible. And I liken this to a little bit about our decision making, certainly from my experience at an academic medical center pre-COVID. We were very good about taking the circuitous route to decisions. We would have committee after committee after committee, and everyone would weigh in, and we would think, and then we would think some more, and then we would send it back, and we would tweak it and wordsmith. And ultimately, perhaps months, years later, we would arrive at a decision. The decision was often very good, I will say, because we had so much input. It was very, very good. We do not have that luxury now at this moment in time. Instead, what we need to do is this, what I call the sidling hill maneuver. This is sidling hill. So if any of you travel on I-68 and you're going from Baltimore to Southern Ohio, you will go through Sidling Hill. They basically blasted a path through mountains. If you look at the top of the crest to the bottom, 340 feet deep, it took 2,600 tons of explosives, and it shaved, and then they opened up I-68 on either side. This shaved hours off my commute. Okay, this is what we need to do in healthcare. We need to be quicker in our decision-making, every bit as thorough, but we don't have the luxury of time. And we need to really put some heft behind our growth and our innovation, put it on steroids, so to speak, and innovate to keep up. And like I said, I think this work is really important, because if not, we worry about being irrelevant. And this is where I think a lot of you guys, I'm not as familiar with your group as you guys are, but this partnership of research and clinical care and figuring out how we're going to do things together, applied research in the clinical wards, on the floors, is really going to be crucial to moving this work forward. So if you don't mind, I would like to revisit some of the challenges that I mentioned. To refresh your memory, I talked about staffing as a challenge. And I said, our staffing is going to have to be flexible. We have to figure out new models of care. Number two, we're going to have to figure out centralization and partnerships. We cannot continue to work in silos. And number three, we have to do this all within the confines of putting our patients first and what our patients are telling us they want. We have to prioritize that. So let me start with this notion of how we should be thinking about staffing and overcoming that challenge. I think the first tenet is making sure everyone is working up to the top level of their skill, the top of their license. And so when we look at how we deliver care on the wards, are we helping our nursing staff with all the team members they need so that everyone is doing what they need to do? Do we have CNAs who can do vital signs, who can help with daily rituals of our patients? Do we have the nurses doing what nurses do best, delivering the medications, doing the high-level assessments? How are we doing this? So that jumps right into my big bullet two there, these versatile staffing models. Can we upskill people? In my hospital, we had a very traditional RN heavy care model. Do we need RNs to toilet patients? Should we be thinking about other staff? And so we work in teams. Under employing versatile staffing models, you'll see I have pod models. Can we leverage in an IMC environment or an ICU environment, a nurse who has that kind of skill, that kind of critical care training, overseeing other nurses who are learning those skills? Can we leverage that expertise in a way that allows us to deploy our workforce more efficiently? We've built supplemental staffing units here in our health system. And by this is a way where we, heaven forbid, we would have folks on units get sick. Everyone does, right? We want you to stay home when you're sick. We do not want you coming to work when you're sick. But then because we had no redundancy in our staffing patterns, we would end up closing a bed or two on a unit if people were sick. We can't do that nowadays. So we built our own supplemental staffing unit whereby we have people we can deploy to units to keep those beds open and to make sure patients are still receiving care. And we have staff who love that, right? They like the variety of working in different locations every day. We also developed our internal nursing agency. Here at our hospital, because of the Great Resignation, we've had to rely on agency staff, agency nurses, agency sitters, agency everything. And it's not that agency nurses aren't good, they are, but there's something about knowing your environment where you work day to day that, in my opinion, just makes it safer. A nurse who's been here 3 or 4 years and knows our protocols and our procedures and who everyone on the team is gonna be easier for him or her to do their job and to keep patients safe. So we're developing our own internal nurse agency, whereby we have nurses who are not necessarily interested in a rich benefit structure. They like the variety. They want to go from hospital to hospital in our system. And so can we leverage pay so that we're not putting as much pay into benefits and we're more into take-home pay, and they get what they want? The staffing, maybe they don't want to work 36 hours, 40 hours a week. Maybe they would just want to work part-time. They prioritize different things, and it's been successful. We are rolling it out and seeing a lot of nurses have interest in this type of model. And then finally, developing our own pipeline. We have to really ramp up our training programs. And we're reaching out, partnering with community colleges, partnering with other colleges in the area to say, hey, we can provide the setting to provide training. And we started addressing our own critical shortages. We have CNA training programs now, surgical tech training programs, pharmaceutical tech training programs, phlebotomy training programs. And it's very successful because people, when they train in a place, they often become very fond of that place and want to stay. So we've embraced a lot of those models. So that's all I want to say about staffing for now. I don't think the end of our staffing shortage is a month or two off. I don't. I think it's several years, but I do think hopefully we are going in the right direction. You will notice I didn't put on this slide sort of the basics of recruitment and retention, because we all work on those all the time. Do we offer market competitive wages? Do we provide an environment that brings joy? Do we have the right wellness programs in our walls? Those go without saying. Those are foundational, and I apologize if I didn't mention those, but please don't think it's because we're not thinking about those fundamentals every single day. I want to talk a little bit about centralization and partnerships, because I think this is very important going forward. The electronic medical record, communication across the healthcare continuum. You know, I remember early on, I was here. In fact, one of my duties when I was a vice chair of our department was to roll out our electronic medical record. We were rolling it out here in the hospital, and my job was to oversee the Department of Medicine work in this area. And I remember meeting after meeting and building it, and how are we going to make sure we don't have alert fatigue and click fatigue, and that it really becomes a tool we all value. And I think we're getting there. At my institution, we use Epic. I know some people use Cerner. I do think we're getting there within our institutions, where we're starting to leverage the power of an EMR for convenience and safety, but we still are not good about communicating across venues, hospital to hospital communication. It's a blank box to me when my patient goes to a skilled nursing facility. Luckily, we have our own home health care group here. And so if a patient requires home health, and it's our Hopkins home health agency, it's become seamless. It's beautiful. Then the home health nurse communicates with me. I need an order for this. What do you think about this? But you go outside your system, we're not there. I often wonder if we made a fundamental mistake as a country in not making our medical record a utility. There are certain things that are fundamental that as a society we have said, this can't be owned by local jurisdictions or states. We have to do it on a national level. Think about our interstate highway system. Think about utilities, gas and electric. We have decided those are so absolutely crucial that we need a different approach. I often wonder if we should have made our electronic medical record a utility and just picked one company as the US and said, okay, we're buying out the others and everyone's going to use this. And this, I mean, the VA system did that, right? Should we have done that in a bigger fashion so that we're not still 20 years later talking about interoperability? Multidisciplinary care coordination, the second bullet on this slide. This is when I give you that first example about we all have the loved one with cancer, and how do you even begin to navigate that? I think we have to be better at this, right? We have to figure out how we run our clinics so that everyone is there at the table. We're better at it in the hospital, where we have multidisciplinary rounds and we have a care manager, we have the nurse, we have the physician provider, we have physical therapy, we have everyone around the table trying to figure out what do we need to do for this patient and planning forward. Well, we have to do this in the ambulatory setting as well. I would argue that that same multidisciplinary cancer clinic with the surgeon and the medical oncologist and the radiation oncologist also needs to have social work and case management. They probably need to have palliative care there in certain circumstances, and they certainly need physical therapy, occupational therapy, and the like, right? We have to work as a team in the ambulatory arena as well. My third bullet, program placement. Patients want convenience. They don't want to drive into Baltimore and try to figure out, we have a massive campus here, multiple buildings. We have a little wayfinding app we rolled out, so you can download it and it'll use GPS in your phone and talk you through your appointments, where you go, which elevator, where to park. It'll walk you back to your car because it remembers where your car is. But it's still a hassle, right? People would rather get care close to home. So where are we putting programs in our health system is important. If it's run-of-the-mill clinic, like a primary care clinic, like a routine cardiology clinic, should we be doing that in a medical facility sprinkled around Baltimore instead of making everyone drive in? The same goes for our surgical care. Should we be doing certain procedures in an ambulatory surgery center instead of here at the mothership where it can be very difficult to navigate? The answer is yes. I ask those questions rhetorically. The answer is absolutely yes. And so thinking through how we do that as a system. Resource management. Oh my gosh. At our hospital, we run on average 90 to 95% occupancy every single day. There is no flex. It has to be a well-oiled machine. We partnered with GE, once again, a partnership, right? Part of the slide is talking about partnerships. We partnered with GE Healthcare to help design a capacity command center. I should have put a picture in here. It looks like NASA. It is unbelievable. We decided that we had to coordinate our bed use at the macro level. If you think about a hospital like Hopkins, we have people coming in through admitting. We have people coming in through the emergency department. We have people coming in from clinics. And then as a tertiary quaternary care center, we have people coming in by ambulance up and down the mid-Atlantic. We run a helicopter system, people coming in through helicopter. How do we manage all those patients and prioritize the sickest? How do we monitor how quickly we're turning over our beds, what kind of staffing we need? We developed this command center. All those information feeds, what beds are open, what beds need to be cleaned, what patients are waiting for. Do we need to deploy the echo team because someone needs an echo for discharge? Do we need to do this? Where are the location of our ambulances and our helicopters? All of our employees who work on that, operators, shift coordinators, sit together in the command center and get real-time data feeds that refresh every 3 minutes so they can coordinate this care as seamlessly as they possibly can. And we're proud of that command center. Several other hospitals have replicated across the country. But that's what we need to do. We need to manage these resources efficiently. Supply chain, we shouldn't be buying things as an individual hospital. We should be buying things as a health system and really thinking through, because that provides value to our patients. If we can leverage our buying power, and especially nowadays in the days of endless shortages, can we figure out how to better not just purchase equipment and supplies, but also transport them across hospitals in our system so that no one is short? Capital planning, same thing, we're doing this as a system. And then finally, as I talk about partnerships, centralization partnerships, we need to look into post-acute. I heard many of you work in big rehab hospitals. We need to partner with you and do this better. Same with our skilled nursing facilities. Do we have the right level of provider? I think, when I trained, we often had patients come to the emergency department with a simple urinary tract infection, but in an elderly 85-year-old, that can cause delirium, and they would end up coming to the emergency department, going upstairs for 12 hours, getting an antibiotic, and then going right back. It's not very patient-centered. Do we have the right providers in our skilled nursing facilities? Should there be nurse practitioners or PAs there who can recognize and treat in place? What's our communication patterns with our SNFs? So all of this work, I think partnering together to allow seamless connectivity is really the way to go. And then I really am coming to an end, I promise. I want to talk a little bit about patient needs. Once again, I have that horrible word, the C word, consumer, making sure patients' consumer needs will be set. And I don't look at that as a bad thing. I'm a consumer, I'm a patient. How do we make sure we're getting them what they want and need to be successful in their own healthcare? Well, as I just alluded to on the last slide, expansion of ambulatory networks is key. Bringing care to our patients instead of making patients drive to us. And I know your hospitals and health systems are thinking in that same way. What do we need to open up so that that care becomes convenient? Telemedicine? Oh my gosh, this has been such a success story for us, and I know you as well. I remember in February of 2020, we were doing about 70 telehealth visits a month. And we had a plan. It was a 3 to 5 year plan on how we were going to expand telemedicine. Then COVID hit, People, we had to shut down elective surgeries. We had to be very careful about our clinics so that patients coming in with COVID symptoms didn't accidentally infect other folks. We went from 0 to 60. Maybe I'll use that highway analogy again, 0 to 60 in the course of months, not years. It was actually weeks. So if you fast forward from February to later that spring, May of 2020, we went from 70 telemedicine visits a month to 90,000. It was crazy. And now some people are coming back in person. So we've settled out at a lower number. But my point is, we used explosive sidling hill type decision making to take a 5-year plan and roll it out in 3 months. And patients love it. I still practice, I'm a general internist. Even my patients who are 85, I'm like, oh my gosh, they're never going to be able to do this. They love it. They don't have to come in, drive, find a parking spot, pay for parking. They can get a lot of that face-to-face healthcare done right from the convenience of their living room. So I use that as an example because I think this is really how we need to embrace convenience for our patients. Patient portals, self-scheduling, communication with providers. Those of you who see patients, there's good and bad to this because we love it that we're able to communicate and do refills electronically. We haven't quite figured out some of the bureaucratic pieces of it. So we need to figure out who's answering what messages and when. But the overall tenor of facilitating communication from patient and provider team is a good one. And it is going to lead to better health outcomes because we all know the patient leaves the office visit and they get home and they're like, oh my gosh, what did the doctor tell me? Oh, I forget. Was I supposed to take this once a day or twice a day? Now it's a quick little message on the patient portal that's easily answered and mistakes are not made. Drive-through options. This I love because, I'm the coffee girl that wants my coffee there waiting on me. I like that convenience, whether it's drive-through or whatever. We started rolling out this in COVID in several areas. We had drive-through tents for vaccines and COVID testing, but our cancer center took it to a whole nother level. They said, you know what? We're worried about our patients. Many of them are immunocompromised, immunosuppressed because they're undergoing chemo. They don't want to come into our buildings because they're scared. Can we deliver the care to them from their car? Drive-through curbside cancer care. So they rolled it out, they piloted it, and we're still doing it today because our patients love it. You can drive up in your car as a cancer patient and not just get a COVID test. You can get any vaccine you need. You can have your port flushed and cleaned. You can get your blood drawn, like if you need to see, are you neutropenic or not. You can get your GCSF injected, all from your car. People Uber in, taxi in. It's really been a model of its kind. And we're looking at, are there other disease states that really lend themselves to this kind of convenience for our patients? So I will move to, I'm really down to the home stretch here. I'm looking at the time. I want to save time for questions. This seamless patient experience is what we all crave through partnerships, through collaboration, through convenience. I put here a few things that I think I see coming down the pike. Health devices, watches, we know, monitor our steps. They monitor our sleep quality, Fitbit, on and on. Clothing is being designed now that will monitor all kinds of physiologic parameters. I think that's going to be very helpful for those of you in the physical therapy arena. You're going to have so much information. The trick is going to be converting that data to information that you can use. We have kits at home. You can measure blood pressure. There are now ultrasound machines people can use at home and submit ultrasound data through the EMR for virtual visits. We have drone delivery of medications. Amazon is working on this like no tomorrow. I must tell you, it is not a secret that why do we need vehicles up and down the highways? Can't we just use drones? Do we need personal concierges, chatbots, personal, IT, AI powered personal concierges for each patient that can help them navigate? And so I'd like to sum this up with a scenario that, remember, I told you I'm a mom. I have a 13-year-old and a 17-year-old. I work long hours. So I do know what it was like to have little kids who have sore throats. Let me paint a picture for you of where I think we need to go. So I wake up one day at 6 a.m. I am alerted from my phone that a bunch of things have been set up for me. My child has a sore throat and a fever. I go in to look at my child, and I know that because my child slept on sheets that are wired to monitor physiologic parameters like temperature. The sheets connected through Wi-Fi to my electronic medical record, which understood there was a temperature, and have already notified my pediatrician's office and set up a visit for me, a virtual visit through the sick hours they have every morning at 7 a.m. I take out my home otoscope. I put it to my child's ear. That image is transmitted virtually during our virtual visit to the pediatrician, who confirms, oh, yes, this is a sore throat. The pediatrician prescribes the antibiotic for my child that seamlessly connects to the drugstore that deploys the drone to my house within 20 minutes, and I have the prescription I need for my daughter. Now, in the meantime, the electronic medical record, I gave permission to contact my employer, who has nanny network services available to me as a benefit. So my employer has already contacted Nanny Network and sent a nanny to my house to stay with my child. So I woke up at 6, and by 7:30, I'm already in my car on the way to the work. I have comfort my child has the antibiotic, the diagnosis, and the reliable home care my child needs. That is what patients want. That is where we need to go. So I laugh here. Look at this Jetsons picture. I grew up watching the Jetsons. This is going to be reality. So I will just summarize, you guys, we have a lot of partnership we can do. This is going to require intense research, quick research. We've got to do applied research. So I think there's plenty of ways for hospitals, health systems to collaborate with real clinicians who have great ideas and can bring things to the wards. I put a couple of tips here, things that I look for. Are you going to help us answer critical questions? Do you connect to our strategic plan? Can we embed research in clinical care? Is the timing right? And we all know innovative ideas and research plus partnership means we will have forward motion to conquer all of these challenges that I've left you with today.